Welcome to The Explainer. So today, we're decoding a really fascinating medical mystery. We're going to explore something that perfectly bridges the gap between basic human anatomy and, honestly, high-stakes clinical practice. Get ready, because we are unpacking one of the most legendary physical signs in all of medicine. I want you to imagine this clinical puzzle for a second. You've got a 58-year-old male walking into your outpatient clinic. He's complaining of vague stomach pain, early satiety, and he's dropped like 10 kilograms over the last 3 months. But when you examine his abdomen, it's completely soft, totally normal, no palpable mass. But when you have him sit upright, relax his neck, and you roll your fingers over his left supraclavicular fossa, right deep behind the clavicular head of the sternocleidomastoid muscle, you feel a 2.5 centimeter stony hard fixed lump. It's completely non-tender. So why on earth does a malignant tumor starting all the way down in the belly pop up as an isolated lump in the left neck? Okay, let's dive into this.
Section 1. Meet Virchow's node.
So this single physical sign is an absolutely vital clue to a hidden story. This is Virchow's node. By definition, it's an enlarged, firm-to-hard left supraclavicular lymph node, anatomically sitting right at the level VB and IV junction. This was historically identified way back in 1848 by the brilliant pathologist Rudolf Virchow. And let me tell you, finding this specific node instantly changes a patient's prognosis. Why? Because it tells us there's an advanced occult, which just means hidden, intra-abdominal or intrathoracic malignancy going on. Now, you're probably going to hear another name attached to this discovery, and that's Treisser's sign. So while Virchow's node refers to the actual anatomical structure itself, Treisser's sign is the clinical phenomenon of actually palpating that enlarged node. This was a concept expanded on by Charles Emile Treisser in 1889. Honestly, in everyday clinical practice, you'll hear us use both of these terms interchangeably to describe this exact same critical finding. The sheer variety of primary malignant culprits responsible for this sign is just staggering. While gastric adenocarcinoma, stomach cancer, is the absolute classic culprit here, this node can actually signal malignancies from all over the gastrointestinal and genitourinary tracts. We're talking pancreatic cancer, esophageal, colorectal, and even ovarian, testicular, and renal cell carcinomas. It really begs the question, right? How on earth do cells from a tumor in the ovary or the pancreas end up trapped all the way up in the left side of the neck?
Section 2. The lymphatic highway system.
To figure out the why behind this left neck presentation, we really have to look at the pathophysiology. I want you to visualize your own lymphatic circulation as a complex interstate highway system, and it is highly asymmetrical. Get this, lymphatic fluid and cellular waste from 3/4 of your entire body, so that's both legs, your abdomen, your pelvis, the left side of your chest, left arm, and the left side of your head and neck, they all merge onto one single massive transit highway. We call this the thoracic duct. Let's move to and see how this builds step by step. Step 1, the journey kicks off at the chyli cistern, which basically gathers abdominal lymphatic fluid right around the L1 and L2 vertebrae. Then, step 2, the fluid travels up the thoracic duct, ascending straight up through the posterior mediastinum of the chest. And finally, step 3, it hits the terminal junction, where the duct actually arches forward to drain directly into the left venous angle in the neck. So when tumor cells escape a primary tumor in the abdomen, they effectively hitchhike up this exact route. So where exactly does our node fit into all this? Well, microanatomically speaking, Virchow's node sits directly adjacent to the thoracic duct's termination point at the Pirogov angle. That's the junction of the left internal jugular and left subclavian veins. Think of Virchow's node as the final security toll booth stationed in the left neck right before this massive interstate highway merges back into the bloodstream. But how do the cells actually get stuffed into the node itself? Well, as this quote perfectly illustrates, traffic congestion and retrograde reflux force tumor emboli directly into this final neck toll booth. Basically, as the thoracic duct gets close to its junction with the subclavian vein, high venous pressure or even a partial obstruction from tumor microemboli causes a massive traffic jam. This literally forces the lymphatic fluid, along with those hitchhiking cancer cells, to flow backward, in retrograde, right into the nearby left supraclavicular lymphatic channels, which swells up the node.
Section 3. Staging. The 2 a.m. clinical stakes.
So the crucial point is that this microanatomy changes absolutely everything in real-world practice. Just look at the stark contrast here. In a patient with a localized gastric tumor, they're prime candidates for curative intent surgery, something like a D2 gastrectomy. But if a Virchow's node is present,
The entire paradigm shifts. According to the AJCC's 8th and 9th editions, finding this single node automatically flips what you thought was a localized, curable case right into M1, stage 4, distant metastatic disease. The treatment plan instantly goes from curative surgery to systemic palliative therapy.
And this is exactly why your physical exam is paramount. If a surgeon misses this node and just blindly proceeds with a curative intent gastrectomy, they are operating on a patient whose tumor has already reached a distant systemic stage. As our source material powerfully notes, missing this sign means, and I quote, subjecting them to high morbidity surgery with zero survival benefit. It's a grave danger and, honestly, a completely avoidable surgical error if a proper exam is done.
Section 4. Diagnosis and clinical pearls.
Okay, so how do clinicians actually manage a suspected Virchow's node? The absolutely first choice diagnostic tool here is an ultrasound-guided core needle biopsy. The NCCN guidelines heavily prefer this specific method. Why? Because a core needle biopsy grabs the actual tissue architecture you need for detailed chemical testing, and it does it without the severe risks that come with open surgery in the neck. Once that tissue is extracted, pathologists use immunohistochemistry, or IHC. Think of these like a set of chemical fingerprints used to trace the tumor back to its unknown origin. Check out these markers. If it's CK7, CK20, or CDX2 positive, the primary tumor is very likely gastrointestinal. TTF1, that points to a pulmonary origin. PAX8 points to the ovaries, and OCT4 points straight to testicular primaries. This panel acts as an incredible detective tool to hunt down that hidden primary tumor in the abdomen or chest.
But guys, here's a massive warning for any clinician listening. Avoid aggressive blind excisional biopsies. You might be super tempted to just numb the area up and cut the node out to send to the lab. But doing this blindly in the supraclavicular fossa is incredibly dangerous. You literally risk hitting the internal jugular vein or completely severing the phrenic nerve. And beyond just nerves and veins, there's what surgeons call the thoracic duct leak trap. Inadvertent transection of the terminal thoracic duct during a sloppy biopsy leads to a massive chylous fistula. That is basically lymphatic fluid leaking uncontrollably right into the neck or chest. This is an absolute nightmare complication. It requires prolonged bowel rest, medications like octreotide, or even highly invasive surgical ligation just to fix it. So yeah, always use image guidance.
Now for a classic bedside pearl that is super helpful to keep in your back pocket, look left for abdomen, right for thorax. As we've learned, the left supraclavicular node, Virchow's, points to abdominal or pelvic origins. But if you find an enlarged node on the right supraclavicular side, which is often called an Irish node, that specific lymphatic drainage pattern points you toward a thoracic etiology, like right lung or esophageal cancers.
And this brilliantly illustrates how medicine is just full of these historical, eponymous nodes that map out primary malignancies. We have Virchow's in the left neck. We just talked about the Irish node, which can also pop up in the left anterior axillary fold. Then we have the Sister Mary Joseph node right in the periumbilical region, the Krukenberg tumor dropping into the ovaries, and the Bloomer shelf felt in the pelvic cul-de-sac. Each specific location gives us a unique map back to a primary malignancy.
Speaking of those other nodes, there's a really crucial dual sign you need to be aware of. If you spot a Virchow's node in the neck, you must always inspect the patient's umbilicus. Finding a Virchow's node and a Sister Mary Joseph node at the belly button at the same time is the classic clinical sign of severe, widespread peritoneal cancer dissemination. Spotting both means the disease has basically hijacked multiple lymphatic and transperitoneal highways all at once.
We've covered a ton of ground today, right? From anatomical highways to high-stakes, 2 a.m. decisions. And honestly, it really leaves you wondering, in an era of multi-million-dollar MRI and PET scanners, could the most powerful diagnostic tool still just be a careful touch at the bedside? Now, I want to hear from you guys. Which eponymous node or clinical mystery should we break down in our next explainer? Drop your choice in the comments below. Thank you so much for learning with me today, and I'll catch you in the next one.